Thank you for that introduction, and I appreciate the opportunity to share our experience tracking linac-based SRS patients using sgrt. So my talk does fall in the treatment section of sgrt use. My only disclosure is that VisionRT did cover my travel expenses for this conference. So a little about Atrium Health and the Levine Cancer Institute. We serve the Charlotte, North Carolina metro area. We have more than 40 hospitals and 900 care locations. We have more than 65,000 employees, which makes us the largest health system in North and South Carolina. We have 9 radiation oncology clinics, and you can see those on that map. Each clinic is indicated by a star. I work at this one up here in kind of the northeast corner. We have 13 linacs, 11 of them have sgrt. We are currently building a proton center down here in Charlotte, and that system will also have an sgrt system. We're treating over 360 patients per day across the system, and we recently combined with Wake Forest University Medical School, and that serves as the academic core for Atrium Health. So the objectives for my talk are to understand the benefits of sgrt for SRS treatments and to evaluate the potential dosimetric consequences of undetected intrafraction motion during SRS. We published this research earlier this year in Advances in Radiation Oncology. So if you want more details than what I can provide in this presentation, please go look up our paper, or you can contact me. I'll be glad to send it to you. And I'd like to thank all of my colleagues and collaborators for helping with this study. So we've known for a long time that surface guidance is suitable for SRS. This paper is almost 10 years old. It came from UC San Diego, and they're publishing their clinical results for frameless surface image-guided radiosurgery, and they are reporting clinical outcomes, local control, and overall survival. So the present study, this was published in 2014, is the bottom row here, and they're just comparing to other previous studies, mostly using frame-based linac. There's a gamma knife, there's some frameless linac, and there's a gamma knife study in there too. The next to bottom row is the same group, and so the 2014 paper is just an update with more patients and more follow-up. And so what you can see is that the surface image guidance, image-guided radiosurgery on the linac provides comparable or better local control and overall survival than the other methods presented here in this table. So that gives us a lot of confidence in using this technology for SRS. So why should we use intrafracture monitoring during SRS? 2 of our primary professional societies provides that kind of guidance. AAPM TG 101 excuse me, says that after localization, some kind of monitoring is desirable to track the patient breathing and monitor patient positioning during treatment. Likewise, the Astro SRS SBRT white paper says something similar. You want to monitor patient motion during these high dose per treatment, these high dose per fraction treatments. So we wanted to understand the dosimetric consequences of not monitoring the patient. What would happen if the patient moved and we didn't know about it? These are our patient characteristics. We have 25 patients. They are evenly distributed between cone and MLC treatments. Boy, that's really hard to see. We did have several different dose per fraction. Most of them were single fractions. Some were 3, 9 gray times 3. Let's see what else. Is there any way to make this bigger and not show the notes in the next slide? Yes, perfect, thank you. So we provide here our median GTV volume, also the PTV volume. We did have a range of margins. Most commonly, we use 1 millimeter GTV to PTV margin. We did have one patient that used 0, a couple that used 2 millimeters, and then one that used 3 millimeters. We use an SRS-specific immobilization open-face mask. True implanting is 1 millimeter thick CT fused with 1 millimeter slice thickness MRI. This is an example of a cone case. The cone patients were the smaller lesions, more suitable to cones. The MLC cases, as indicated here on the right, those were larger tumors, maybe more irregularly shaped or close to a organ at risk that we needed to avoid. We used 6 triple F beams on a true beam. This is a typical ROI we used for monitoring our SRS patients. Our sgrt tolerances for these cases were 1 millimeter and 1 degree. We took an sgrt reference capture before doing the pretreatment cone beam. This allows us to monitor while we're imaging and while the MD is matching the image. I know I'm sweating there while the MD is taking 2 or 3 minutes to do the match. I'm like, let's get this moving. So we want to know if the patient does move before we finish that match procedure. The MD matches the cone beam, we shift, and then we take another sgrt reference. This reference is what we use to monitor during the treatment. Our linac is interlocked with sgrt, so I'm relieved to see that the latency is quite small and the beam turns off fairly quickly after the patient goes out of tolerance. So if the patient does go out of tolerance, then I left out a step here. We do take another reference, and that's what we monitor with while we do the repeat cone beam CT. The physician makes any shifts that are needed, and then we take another sgrt reference for monitoring and continue with treatment. So from January of 2017 to September of 2020, we treated a total of 55 patients, SRS patients monitoring with sgrt. The 25 patients from that table on the previous slide, those were the ones that had an intrafraction 3D vector shift from the cone beam that was 1 millimeter or more. We chose 1 millimeter because that was our most common margin. And so these are the summaries of the shifts from those 25 patients. You can see this is the median shift was 1.5 millimeters. The range was from 1 to 6.6 millimeters. So quite a large maximum shift that we saw, more than double what our largest margin was. I'll point out that the rotations were very small, and we ended up not taking those into account in our simulated dosimetry. So to do the simulated dosimetry, we took the intrafraction cone beam shifts and we went back to the plan, we copied it, and we shifted the isocenter in the treatment plan according to the intrafraction shifts, both the direction and the magnitude. As I said, we did ignore rotations. They were very small, and other studies have shown that they don't make very much difference for a single ISO placed in the center of the target. Key disclaimer there. And so that gave us an estimated of the delivered dose if the motion had not been detected. We did assume that the motion occurred before treatment began, so the entire fraction was delivered with the patient offset. That's not an unreasonable assumption. We did see patients move during the cone beam and the matching. So we also had one patient we could not do SRS on because he could not stay still, and he ended up being transitioned to whole brain. So that kind of thing does happen. The dosimetric analysis was PTV coverage, the GTV minimum dose, and V12. V12 is important. It's the dose, it's the volume of normal brain that gets 12 gray. A couple papers or guidelines recommend limiting V12. This is the Astro Clinical Practice Guideline. They recommend a conditional recommendation limiting V12 to less than 10 cc's. And then the high-tech publication also follows the Quantec recommendation to limit it to less than 5 to 10. We try to limit to less than 10 cc's. So these are the results. V12 PTV coverage, or GTV minimum dose as a percentage of the prescription dose, the PTV coverage, and the GTV absolute minimum dose. The actual column is from the treatment plan. The simulated column is from the shifted isocenter plan. The median differences, and then the p-value for the Wilcoxon-Snyder test. You can see that all four of those differences were statistically significant. The V12 difference is not clinically significant, but it was statistically. But you can see here the minimum GTV dose changed by a median of about 3 gray, so that's quite a significant underdose if you're trying to give 21 gray, and you only ended up giving 18, so that could be a problem. This is an example patient. The red contour here is the GTV, the blue contour is the PTV, and then the purplish line is the prescription isodose line. So on the left, this is the treatment plan, and then on the right is the shifted simulated dosimetry. You can see the shift of the isodose distribution and how not only we're underdosing the PTV, but also the GTV there. This is the DVH for that patient. Again, the bluish is the PTV, the red is the GTV, and the squares are the planned, and the triangles are the shifted dosimetry. So you can see quite a drop in coverage, both the PTV and the GTV, due to the intrafractional motion that this patient exhibited. There have been other studies that have looked at dosimetry for patient shifts during SRS, but ours was different, I think, in a couple of important ways. This was from 2012. They did a Colby CT at the end of treatment. They took those shifts and they recalculated the dose much in the same way we did. And so this is a summary of their shifts. Their 3D vector average was about 1 millimeter. Their max was only about 3 millimeters, so half of the maximum that we saw. And then their dosimetry, they only saw underdoses or PTVs getting less than 95% of the dose in 14% of patients if they had 0 margin. Once they added a 1 millimeter margin or larger, all patients still got 95%. The key difference here is that they're basing this off imaging at the end of treatment. For a long time, that's the best we could do. I've done that, but they don't know anything about where the patient was during the treatment. They only know we only knew where the patient was at the end. So it's kind of apples and oranges if you have a continuous monitoring during treatment. The paper on the right, that's for Gamma Knife. This is the ratio of the D99%, and this is ratio of coverage as plotted for target versus target volume. They didn't use actual patient motion. They just chose 5, 0.5, and 1.5 millimeter shifts. So they're simulating that, but they don't even know if those are real patient motions. The paper states that their next step is to perform this with actual patient motion. So whereas our study, we did actually use that patient's motion applied to that patient's plan to calculate the dose. Why is this important? I think we all want to give the prescription dose to the target, but it's very important in radiosurgery. I've got here 3 studies. Each one found that a minimum GTV dose is important to local control. The first one on the right or on the left is a multivariate analysis. The only factor that correlated with local control was the minimum tumor dose. The middle one, they found a decrease in 2-year local control if the local control was only 51% versus 90% if the mean minimum GTV dose was about 15 gray versus 17 gray. And then on the right, that's for fractionated radiotherapy, fractionated stereotactic radiotherapy. They found that the GTV 98% is a strong reproducible factor for local control. So you want to maintain that minimum dose to the GTV for good local control. So in conclusion, we found that SGRTs attractive for patients set up in monitoring. At least in our clinic, patients do move a lot or can move a lot during SRS. That may not be true in your clinic. We do believe that continuous monitoring during SRS is necessary, and intrafraction motion can lead to large underdoses and possibly worse local control. So thank you for your attention.